There's relatively sluggish flow in the splenic vein. That first impression is important. You can see on screen that that was relatively stagnant. That's going to tell us something about the portal pressure and also our desire to move quickly. So this is a great sigh of relief in every case for anybody who does TIPS, because we are secured, we're across, and we've gotten through the first several events, and now we kind of see the end in sight. So I'm going to connect up to our pressure transducer. I'm guessing a portal pressure of 31. Let's see what we get. I see a 36. Come on, come down a little bit. I'm not going to have my number today. So our initial portal pressure is 37. Remember, the atrial pressure is relatively high to begin with, but that gradient is substantial, and there was a clue to that, not only from the big spleen, but from the sluggish flow. So we're going to put on our speed shoes to get some decompression in. So let's have the 180 amplats guide wire. I'm sure he didn't have his morning diuretics. Can we give him 80 milligrams of Lasix, since he takes 200? Because we'll be elevating his portal pressure, and once again, we want our infused fluids to be as minimal as possible, notwithstanding the platelets that we have to give him. So it's very important to maintain good wire control at this point. So I'll mentally assign an acceptable position for the wire, which is, as you see on screen in this case, this very large splenic vein. We're adding a little extra step here. I want to get the sheath into position a little bit further down, and then we'll do our initial splenic venogram. You can choose to do it in the opposite direction, order.
Wire. Wire.
I'm going to advance quickly, a little bit of tension, a little more. Great. And you know, since we got the balloon down, I'm going to do something slightly differently. We'll do our portal vein entry run here, our initial splenic venogram, and then we'll just back it up and dilate. But I'm comfortable now because I know that we're going to be able to get all our equipment into place and get that sheath down. All right, so you see that I'm in some small gastric branches, and it's always while I inject lightly at the beginning. Even if I had free flow a moment ago, I'll always inject lightly, because the patient may breathe down into the catheter, and then you can actually do some serious damage by over injecting something small. So I'll start small and slowly increase during the injection. And trust me, that looks entirely like the MR. There is a recanalized umbilical vein that was faintly visible. Okay, but our real pictures in terms of mapping and positioning are going to come with injecting the tract. This procedure is being done, and we can send over a reference image from that one. Let's send that reference image over. This procedure is being done purely for pressure reduction, not for varices. So that picture of the large venogram is not essential, and if his creatinine were elevated and his GFR were low, as it often is in the ascites patients, I may not even have taken that picture that I did, saving all my imaging and contrast, or I'd be using CO2. So we're going to do our ballooning. The first thing I did was bring the colapinto sheath back into the outer sheath, so I don't have to have the risk of inadvertently dilating that sheath, which doesn't have a radiopaque tip. The next thing I'm going to do is pin the balloon and bring the sheath all the way back to the top of the hepatic vein, because we're going to dilate all the way back. And why have to move it in steps? And now we're going to bring the balloon back into position for the first dilation. We'll make an estimate there. Great. Please go up in pressure. I can hold the wire if you'd like. Great. Let's take it all the way up to 12 or 16 atmospheres.
12.
Okay, and I think we're at the very bottom of the portal vein, so entry site. So we'll deflate And even before complete deflation, I'm going to start to pull it back because we'll see the impression of the balloon. So let's reinflate there. Okay, we'll make that impression disappear. Show it who's boss. Your boss.
And holding.
All right, deflate, 16 atmospheres. In the meanwhile, I'm going to bring the, you have some instant replay there, we're going to bring the sheath back a little bit more, and we're going to bring the balloon back more to do the hepatic vein exit site, which is there. A lesser impression, go ahead and dilate that. And that's the hepatic vein exit site. So it's really a rather short track. Things were tight, as expected. Okay, and now we'll deflate. It's up to you whether to dilate that more than once. I don't necessarily see the necessity, but we will do one important thing once the balloon has been deflated. We'll wait for that, and that's rule number 2, keep the sheath down. So my goal now is to get the outer sheath all the way down into the portal vein, both so that we don't have a misadventure backing out our equipment and losing access, but or more importantly, because the next step is going to be measuring and delivering a stent graft, I want to assure that the sheath can move readily in and out of the tract so that there won't be any surprises when we come to device delivery. So I'm going to advance the balloon back in. I'm going to secure the wire, and we can disconnect the tubing. Thank you. And then over the balloon, I'm going to try to advance the sheath in some combination. And there's rule number 2. Okay. Let's get the balloon out. If you'd be so kind as to hold the guide wire. Okay, I like to take the sheath and the balloon out together because it's less messy. So I'm going to bring the colp into a sheath, pinch pull it all the way back to the hub of the balloon so that the two are near mated. And now I'm going to take the back of the wire so that you can take the two out together.
Okay.
So if you'll just, here, you can stand over here and back the two out over here. Yep,
Let's choose a unit.
exactly.
Okay.
Pinch pull. Okay. There's no reason to continuously use fluoroscopy. Notice that we're using the least magnification for as much as possible to keep our doses down. Both for us, for personnel, and for our patient. And there's the balloon. So, okay, I'm going to push the balloon back off to you.
Pulling wire towards you.
I have the wire, and we'll need to wipe that. Okay. Wiping a wire toward is always more sound than wiping back because there isn't a chance that you'll inadvertently remove the wire.